Well, good evening and welcome to Therapy Ed's online office hours. My name is Colleen Maher and I'll be your instructor for the evening. And I'm very fortunate because I have Dr. Rita Fleming Castaldi here as my co-host, and she'll be helping to answer some of the questions in the chat. And so if you have any questions, please go to the chat. Now, this topic tonight is specific to physical agent modalities and therapeutic exercises. And then we're going to have an open-ended Q&A session. So just some important information here, copyright compliance. This session is the property of Therapy Ed. All portions of this online office hour are protected by copyright. Therapy Ed does not allow any kind of audio recordings, video recordings, pictures or screenshots, storage and or transmission of course information electronically or other means such as Quizlet. We reserve the right to immediately restrict access to our online office hours for anyone who violates the copyright. Thank you for your compliance with these guidelines and our professional ethical standards. Just a couple logistics to make sure that you have a positive experience and decrease distractions. Please keep your mic muted during the session, but do turn your mic on when invited to share your question and any concerns that you might have. Please leave the video on to facilitate personal connections. Mute your video as desired or needed. Tonight's session will be recorded. So that's the good information. It will be recorded and it will be posted within 2 days on Therapy Ed's YouTube channel. The recording will be available for about 1 month. Only the PowerPoint presentation will be posted. To ask questions, please use our chat box. I or Dr. Fleming Castaldi will regularly check it. Before you post a question though, scroll through the chat to see if there's any questions that are similar to yours. This will decrease the repetition and allow for more diverse questions. A review of must-know content that must be mastered to effectively answer the NBCOT exam items today will be again on physical agent modalities and therapeutic exercise. And there is more information on this in Chapter 11 of both the OT and the OTA certification exam review and study guide. So you can find more information in there. And of course, you complement that with all your textbooks. That's going to be most important. I'd like to just start by introducing myself and give you a little bit about my background, and then we're going to go right into the content review. So I started out way back in 1979, before all of you were born, I'm sure, as an occupational therapy assistant. And I was very fortunate at that time. I worked with a wonderful occupational therapist who really made me fall in love with occupational therapy. So when you think today, you know, people say, oh, what's OT? What's that all about? Imagine what it was like 40 years ago when people said, what is OT? And so it was different, but I worked with an OT who was really at the roots of what OT was all about and made me fall in love with the field, and it really got me interested to go further in occupational therapy. So I worked with this person for 7 years. I worked at the Hospital University of Pennsylvania, and I worked in all different departments in the hospital, but I decided to go on. And at that time, it was a bachelor's degree in occupational therapy. So I got my bachelor's degree at Temple University. And then I worked in my first job as an OT. I worked in New York City area at the Hospital for Joint Diseases. And at that time, I worked mainly with orthopedic conditions. I worked with a lot of shoulders and learned a lot about shoulders and the importance of not only addressing them from a biomechanical standpoint, but embedding occupation into that. And that is what made me really become interested in upper extremities. And I went on to take a job in a small community hospital then in New Jersey. And I started out by myself. After 25 years of working there, there were 9 of us. So I was able to build up the department, and we worked with clients throughout the entire hospital. But again, my focus, my interest was in upper extremity orthopedics. I became a certified hand therapist. I also became very interested in cancer management. And so I worked with our radiation oncology department very closely. And I went on to get my certification in lymphedema management. I also, while I was working at the hospital, I went on and I got my post-professional master's in occupational therapy. And after I got that, I started getting asked to do some guest lectures. And slowly, I got worked into Dominican College, which is where I met Rita. Wonderful. And I slowly moved from working in the hospital to then teaching. I moved out of the clinic and into full-time teaching. And I worked in several colleges in the New York area. And then where I'm at right now is I'm at the University of Sciences in Philadelphia. I'm their program director for their master's program. And I also teach in their doctoral program. And on the side, I always try to keep myself in touch with what's current, what's going on out there. So I've done work in rehabs, in home care, in hand therapy centers. So I try to always do some kind of per diem to just stay on top of what's going on out in the field. Right now I'm doing working with Therapeutic, which has been a wonderful experience. I also have my clinical doctorate in occupational therapy, and I'm finished. I'm not going on for my PhD. I'm very happy with where I'm at right now. And I love teaching these sessions. And I think that this program that Therapeutic has put together, these online office hours, as well as the courses, the review courses that they give, is amazing. We did not have that when we had to take our exam. And this is really a wonderful way to really review and prepare for the exam. So now I'm going to go on and I'm just going to start and go after the most important information in regards to physical agent modalities. Now, when you go to your textbooks, there's a lot of information in there. You should be reading it and reviewing everything. I'm going to start out by talking about superficial heat agents, specifically hot pack, paraffin, and flutotherapy, the most common probably physical agent modalities that we use as OTs, along with cold packs. Review your 3 types of heat transfer, your conduction, your convection, and conversion. Go over that. But when you are studying for physical agent modalities, make sure as you go through each physical agent modality, you look at these main things. What are the main indications for this? Why would I use this physical agent modality? What are the contraindications? Very important. Keep in mind, NBCOT, they're concerned about safety. So we want to make sure that you know contraindications, any precautions, and any kind of safety tips. So look as you're reading that you go over that, and then your clinical reasoning. So let's talk just about superficial heat agents. And I'm sort of grouping them together, the hot packs, the paraffin, and the flutotherapy. Some of the main indications when I think of heating modalities, I think about increasing tissue extensibility. If I have a patient who has limited range of motion passively, I am definitely, as long as they don't have any kind of an acute flare-up or just had surgery, I am going to go ahead and definitely consider using a heat modality. So I love to use heat to increase tissue extensibility. So you can take and apply the heat and then follow that up with some kind of exercise and then with some kind of an occupation. And what you do is you end up stretching. You get that tissue extensibility, which you want. So when I think heat, when I think of somebody, if they give you a scenario that, hey, this person has limited passive range of motion, again, if it's not just post-surgical or an acute flare-up, I'm going to be thinking a heat modality. Also, we use hot packs sometimes to help decrease pain and also decrease muscle spasms. Some of the contraindications that you want to keep in mind when you're thinking about heat is if they give you a scenario where the person is post-surgical, somebody who just had like a rotator cuff repair, you're not going to want to put a hot pack on that. You have to have several weeks that go by healing where they're out of that acute stage. Any kind of acute injury or an acute condition. And so when I think about the different conditions, when I think about somebody has rheumatoid arthritis and they have a flare up, I am not going to use heat modalities on somebody who is experiencing a flare up. Anybody who has an infection, not going to use the heat modalities. And one of the major contraindications that everybody should know, if a person has any, if they give you a scenario where the person has any kind of impaired or absent sensation, you are not using heat modalities, okay? It's contraindicated. Even if you've been seeing it maybe used out in the field once in a while, sometimes therapists will give extra toweling and stuff. For the exam, go by what is in the books, and they list it if they have impaired or absent sensation as a contraindication. If they have any kind of impaired circulation, you are not going to be using heat modalities. If they have edema, we're not going to be using heat. We're going to probably use cold. Active cancer or tumors, MS, we're not using. We know that heat is contraindicated. Extreme heat is contraindicated in MS, DVTs, and lymphedema. So these are some of the major contraindications that I see in the textbooks. Now, there are others. So please, again, review your textbooks. But these are some of the most common ones that are out there. Precautions, some of the precautions, fragile skin. We see this with our older population. You want to look and see, what is their skin like? Are they going to be able to tolerate, a hot pack or paraffin? So if their skin looks fragile, that's a precaution. I'm going to be very careful if I'm going to use a hot pack or paraffin or flutotherapy. I might turn the temperature down in the flutotherapy. I might use extra toweling, or I may not use it at all. For children often can't say, hey, this feels too hot, or someone who is cognitively impaired. Safety issues when you're using your heat modalities. Most important is you check the MD's prescription. Make sure that there is an order for the physical agent modality, okay? We're not going to use a physical agent modality if there is no order. So you make sure that there is an order there. If they give you some kind of a scenario and it says that the MD ordered a certain kind of physical agent modality, you want to focus on that. But we as OTs, we need to know like when something might be contraindicated too. So once in a while, it was very rare, but once in a while I would have to call up and say, you ordered this, however, at this time it might be contraindicated. Would it be okay if I use this physical agent modality? Do your skin checks. Know that whenever you're using a physical agent modality, you never start. First off, they're always going to wash their hands or if they can, or if it's the shoulder, you're going to inspect the person's skin first. You want to make sure that there's no open wounds or any kind of blisters or anything like that. You want to check their skin before, if possible, during, and then after the physical agent modality. Now, there are some physical agent modalities that we can't check during. So something like paraffin, we're not going to be able to check their skin. So I'm very cautious when I use paraffin. I make sure that I don't have any concerns that the paraffin might cause any issues with that person's skin, because I'm not going to be able to check it. So that's one thing. Then temperature check of the modalities. So even though like your paraffin machines, your hydrocolators, they already have preset thermometers in there, you get an extra thermometer, you put it in there, and you make sure that that temperature is at the right temperature for that modality. You have a second check. And then certain things that you want to consider, like if you're using a hot pack, how many layers of towels do you use? And so in your books, what I have found is it's anywhere between 6 to 8 layers of towels. Now, if you use a hot pack cover, some of them are saying that you can use the hot pack cover with anywhere between 4 to 6 then layers of towels with it. The most important thing anytime you're using heat is that you're using a dry towel. You're not using a wet towel. You're using a dry towel. And that's important too, because once you put the hot pack away, you want to make certain that you are putting it away and you let the hot pack cover dry up. You don't want to put a wet hot pack cover with wet towels on somebody because it could cause them to burn. So think safety. Whenever they give you a question about any kind of physical agent modalities, especially your heat modalities, think safety. So the hot pack covers are important. And again, like I put somebody in a hot pack, I'm going to check their skin before. Maybe 5 minutes later, I'm going to pull it up, take a look at their skin to see, are they tolerating it okay? If they are, put it back on. And then afterwards, I'm going to check their skin. Just a couple other things. It's important that you think about, do they give you a scenario where a person is limited with raising their arm up over their head? You want to think about, and under clinical reasoning, what structure is involved. So for example, if I can't raise my arm up over my head, chances are it's my inferior joint capsule and ligaments. Okay. But a lot of times people have a tendency to put the hot pack on the superior part of the shoulder. It feels good. It relaxes the shoulder, but the actual structure is inferior. So you want to think about, where do I place this hot pack so it's most effective? Now, when you put a hot pack on someone, the effects of the hot pack are usually good for about anywhere between 30 to 45 minutes. So know that you have that time period that you should be working with that patient, to then follow it up with some kind of exercise and some kind of occupation. So some clinical reasoning, when you get a scenario on the exam, consider the diagnosis. So that's the first thing. Say to yourself, okay, MS is, they're saying, which modality might you use? Oh, it has hot pack here. Oh, I know that's contraindicated, so I'm not going to use it. So be familiar with your different diagnoses and what kind of physical agent modalities are indicated. Know the structures that are involved. Okay, so if somebody has difficulty extending their wrist and their fingers, I'm going to want to make sure that I'm heating up, especially the volar side of the hand. I may sandwich them and put them in a hot pack below and a hot pack volar and a hot pack dorsal. But you need to think about the structures that are involved. And also too, they may have a question too about somebody in home care. We don't always have some of these physical agent modalities available. So how can you modify and do things that might help to give them similar effects? I know that like a lot of times now doctors will order like paraffin machines to be for the person to use at home. So think about the different possibilities depending on the kind of setting that they're in. Also, the patient's input and tolerance. So, some people will right away say, oh, I don't like ice. I don't want to use ice at all. So right away, you have to keep it client-centered and know that this person has probably had ice before and they don't like it. That doesn't mean that you just go ahead and then use heat, especially if they have a flare-up. So in that case, I would probably not use anything. And again, your physical agent modalities are preparatory interventions or methods, actually, or they're considered an intervention to support occupation. So they're not the end all. What you do, what you follow up with is super important, but they complement our Therex. They complement our purposeful activities, our occupation-based activities that we do. And then again, also evidence. Be aware of your evidence, like any kind of evidence. And a lot of times you'll see in your textbooks too, that'll talk about, evidence in regards to the different types of physical agent modalities. Now, superficial cooling agents, or known also as cryotherapy, most common are cold packs and ice massage. So when we use a cold pack, it's more for a general area versus ice massages if you're going at one specific area. So for example, somebody had Decker veins and they had a lot of pain along the radial wrist and into the thumb. I might do ice massage with that person versus an ice pack. So you have to make those determinations. Again, as you're looking at the physical agent modality, you want to think about, what are the indications, contraindications, precautions, safety, and clinical reasoning. So indications for using ice. Number one thing I always think about, somebody has pain, I use ice. Our post-surgical patients, like after a rotator cuff repair, a lot of times they'll come home with an ice pack that was given to them by the hospital. So a lot of them have the ice pack already for use at home. Also, when I think about cold packs and ice, cold packs especially, I think about decreasing edema. And also it's used to help decreasing abnormal tone, and it can actually assist with facilitating tone. Common to use on some post-surgical repairs and acute injuries, but you must find out, and I say some because if a person has a nerve repair, we're not using it. So we're not going to use the physical agent modality if a person has any kind of nerve repair or something like that. They have a rotator cuff repair. They have a wrist fracture. Maybe they had open reduction, internal fixation. They got some swelling and pain. I might use an ice pack for them. Some of the contraindications, again, safety deficits. So impaired or absent sensation, impaired circulation, and Raynaud's disease. Some of the precautions are the same as the heat modalities. So you're going to see some similarities where fragile skin, children, cognitively impaired, they may not be able to tell you, somebody who's cognitively impaired, to say, hey, this feels too cold. Again, though, what are we going to do from a safety standpoint? We're going to first check the MD's prescription to make sure that it says it's okay to use a cold pack. We're going to do skin checks before, during, and after. And then you have to determine, are you going to use a dry towel versus a wet towel? And so, again, a dry towel is not going to penetrate as quickly. So in regards to a cold pack, sometimes we'll use a wet towel and put the cold pack on that. But you must check their skin. Please keep in mind that a person can get a burn from a cold pack. So that can happen too, not just from a hot pack. Again, your clinical reasoning for using your cold packs, consider the diagnosis. So if I, again, have somebody who has some kind of a severe, significant pain or pain at all, I'm going to use an ice pack. If they have edema, I'm going to use an ice pack. Now, one thing I want to say about edema, whatever you do, if you use an ice pack, like on a person's hand that is swollen, you don't want to put their hand flat on a table and put the ice pack. You want to put them in a slightly elevated position and then put the ice pack on that. You want to look at the patient's tolerance to the ice, and then any kind of evidence that can back up your reasoning for using the ice. And there's evidence out there. And then again, we never want to use our physical agent modalities in isolation. So if a doctor orders a patient to come to therapy, let's just say for hot pack and paraffin, we don't do that. It has to be followed up with some kind of purposeful activity or some kind of occupation-based activity. And but if that's what the MD is ordering, we could teach them a home program and then send them home with give them information about, purchasing a paraffin machine or something like that. But we would not be seeing a person just for physical agent modalities. It must be linked to some kind of purposeful activity or some occupation-based activity.
Colleen, there's a question in the chat box, and I also just want to let everyone know that I've been putting in the page numbers in the textbook, because I know this is a lot and it can get overwhelming, but the indications, contraindications, and precautions that Colleen is reviewing are in the review and study guide, 353 to 355 in the OT text, and then it is 333 to 334 in the OTA text, so you can follow along if you have the text. Of course, she's adding her clinical expertise to it and her examples, but the key data is there. And the thing I want to highlight is the precautions that she's talking about. Colleen did a great job of having caution boxes and red flags about those things. So it really calls your attention to it, which is a nice addition. Asuna is asking, can you repeat about using the wet towel versus dry towel? Caitlin, do you mean for both heat modalities and cold, or just for one or the other?
I was just thinking of the cold, but you
Yes.
can say
Okay.
both, it doesn't matter.
Okay, yes. So we would not use a wet towel for hot packs. Okay, so that we know we do not want to use any kind of wet towels, wet hot pack covers. We want them to dry. We're always going to use dry towels for somebody who has hot packs. For cold packs, you will find that they might say to use a wet towel between the person's skin and the cold pack itself. Again, we're always checking their skin. It will allow it to penetrate a little better with the wet towel. But again, we always want to be careful. We don't want anybody to get a burn. So you're constantly checking their skin. And then, but some therapists prefer to use a dry towel between the cold pack and the person's skin. So it's just with a cold pack, you have to determine if you're going to use a wet towel or a dry towel. And I think in your textbooks, they often say, and let me just say, a towel should be placed and be treated to collect water. Yes. So again, they go back and forth. You know, do you use a wet towel or a dry towel? So you'll see it in the textbooks stating that. Okay. Next, I'm going to just.
Sorry,
Oh yes.
I didn't have enough time to type in the chat, but I have just a quick question on just since we're on the cold packs. You mentioned hot packs. It takes 30 to 45 minutes, like for like the after effects for like I guess to like relieve pain. What
Yeah.
would you say about like ice packs? Like, is it typical? Is it just the same amount or is it brief?
Okay, so treatment times are much briefer. So you'll find too that with the treatment times in regards to certain areas, it's going to be brief. Like if you're doing ice massage, that's only for a few minutes. For the ice pack, it's going to be longer, but the effects of it may last a little bit longer. Now, a couple things about that is you can use heat with ice. So I might start out by using a hot pack for like 20 minutes, follow that up with some kind of exercise, some kind of activity, and then I end with ice pack. Sometimes people will use an ice pack on their skin without the wet towel, with a dry towel for longer periods of time because it's not going to penetrate. And you will see that even like with your inpatients after surgery, they'll have an ice pack on and it can be on there for, 20 minutes easily.
And one last question, sorry. How do you know, how do you just like, what would you do? What's like the preferred method? Either an ice pack, like when do you know when to use ice massage or cold pack? Because I've stumbled
Yeah.
upon like a question like this and
Yeah,
they're
that's
both, yeah, so.
yeah, that's a great question, Jessica. So when I use an ice pack, I'll probably use an ice pack um, most of the time. However, if I have somebody who has a very specific area where they have discomfort, like for Decker veins, usually it's on the radial side of the wrist, I might just take and use ice there. Or for lateral epicondylitis, I might use some ice just in that general area there versus if I have somebody who has like their after rotator cuff repair, they're a couple weeks, I did heat, I did range of motion, and now they're having a little bit of soreness from what we just worked on. I'm going to then put an ice pack on them. So that is using your clinical reasoning. So I think of ice packs as, that's going to cover a bigger area. Okay. And where the ice massage is briefer periods of going at very specific areas on the person's whatever structure is involved. Okay. Did that help, Jessica?
Yes, it did. Thank you so much.
You're welcome. So next I'm going to talk about electrical stimulation. And the most common ones I have up here is TENS, neuromuscular stimulation, functional electrical stimulation, and iontophoresis. And so the indications for your electrical modalities, some include pain control. So we use it for pain control. When I think about pain, I especially think about TENS. Decreasing your swelling, muscle re-education, strengthening the muscles, and stimulating denervated muscles. So some of the contraindications, anytime you have a question on, that they give you electrical stimulation as a possibility of an answer, you want to think about the contraindications. So somebody who has a cardiac pacemaker, if they have phrenic or urinary stimulators, thrombosis, thrombophlebitis, carotid sinus, metal hardware, and there are some general contraindications also. We have those all listed too in the book, as well as you want to go to your textbooks. Because again, I'm putting up here some of the more common ones that are listed, but they are, there's others. There are definitely others. The precautions, again, it's the same precautions. You want to watch for somebody who has fragile skin, children, people who are cognitively impaired. Are you going to want to use it on this population? So you want to be very careful. In regards to safety, you want to check the MD's prescription. What are they ordering? What is the purpose of what they're ordering? Sometimes, we might have to guide them, hey, we have somebody who has a radial nerve palsy, but they're starting to get a little bit of movement back. So, hey, I might want to try using some neuromuscular stimulation. If I'm using it for during an occupation, I might say, okay, I'm going to use the functional electrical stimulation. So you need to think about, what are you going to be using this for? So a couple things, skin checks, always skin checks, big safety thing. Know your parameters, protocols, and dosage. For the exam, you should just have a general idea. Again, what is in your textbooks is definitely acceptable of what you should know. Clinical reasoning, you want to consider the diagnosis of what you're treating. So again, if I have somebody who has a lot of pain, I'm probably going to consider TENS. If I have somebody who has a radial nerve palsy, okay, I'm going to consider one of the types of electrical stimulations that are going to help with getting that person's movement back. If somebody has pain, I might consider iontophoresis, okay? And so with the iontophoresis, they're driving the medication in through electrical stimulation. Again, think of what equipment is available and the patient's tolerance. A lot of people do not like the feeling of the electrical stimulation. So you need to try it out with that person and be familiar with parameters, protocols, and dosages. And a lot of times, the machines will come with protocols that will help to guide you, but you always want to initially work with somebody experienced. Follow up or use during TENS purposeful or occupation-based activity. So again, we're not going to use these unless we're following it up with some kind of purposeful or occupation-based activity. Sometimes, like I'll use TENS with somebody who is doing some kind of purposeful activity. So we use it during the activity itself. So you just want to make sure that you are always combining, no matter what physical agent modality it is, with some type of purposeful or occupation-based activity. Ultrasound, we have continuous and pulsed ultrasound. Continuous is known as the thermal part, and pulsed is the non-thermal. So continuous, when you use ultrasound, so it has two parts. So one is continuous. The indications for continuous would be if you're trying to increase extensibility. Again, it's great for increasing the tissue extensibility, reducing pain, increasing blood flow, and reduces muscle spasms. Now, your continuous ultrasound in the textbooks, it'll say anywhere between a depth of 4 to 5 centimeters. Now, personally, I always like to use continuous ultrasound with patients who had like frozen shoulders and stuff. So I might start them out with a hot pack and then follow it up with continuous ultrasound, which I know goes deeper than a hot pack. A hot pack is superficial. We said it only goes about a centimeter, whereas your joint capsule is deeper. So I like to follow it up with ultrasound, continuous ultrasound, follow that up with some kind of exercise, and then follow that up with some kind of occupation. Pulse ultrasound is used to decrease inflammation and for tissue healing. And a lot of times you'll see therapists use the pulsed ultrasound for scar, for helping with scar tissue. Contraindications. There's a lot of contraindications here. Growth plates. Okay, you never want to ultrasound over a growth plate, over fractures, infections, any kind of inflammation, pregnancy, some joint replacements, thrombophlebitis, active cancer tumors, spinal cord, metal hardware, bony prominences, and avoid near any pacemakers or breast implants. These are all important for you to remember because, again, like if I have somebody who has a frozen shoulder, but they had, let's say, breast cancer surgery and now their shoulder is frozen, I'm not going to use ultrasound because if they had an implant and I'd find out if they had an implant, I'm not going to want to use that. Also, too, because they have cancer, I'm not going to use it too close to the site. I would not use it. Precautions are fragile skin, children, cognitively impaired, and soft tissue repairs. So be careful with the pulse ultrasound, especially with any kind of like soft tissue repairs, such early on, such as like tendon repairs. Safety, check with the MD. Make sure you have a prescription for your ultrasound. Do your skin checks always. So if you leave with anything, you're going to remember, I'm checking the prescription. I'm making sure they have their skin is okay before I start and during and after the treatment, if you can. Know your parameters, your protocols, and dosage. And again, for your clinical reasoning, you want to think about what structure am I going after, especially the depth, because again, if you're using continuous, it goes 4 to 5 centimeters. It can go deep. The patient's input or their tolerance for the modality, any kind of evidence that backs it up. And there's some evidence that is very positive towards ultrasound and some that says, yeah, it hasn't been that effective in certain things. So you want to check your evidence and then follow up again with purposeful or occupation-based activity. So again, your choice of modalities are going to be very important for you to think about, okay, what is the diagnosis? What is that structure that I'm going to be really going after? And what is the effects that I'm looking for? And then before you do anything, you're going to make sure you check contraindications. Is there any reason why I shouldn't use this physical agent modality on this patient? So again, PAM should not be used in isolation. You must establish competency for using PAMs as an OT intervention. Also know your State Practice Act, find a mentor, attend competency courses. In school, you learn about PAMs, but it doesn't make you competent. You need to work along someone who can help to guide you or go to a course where you can get your competency training. Indications, precautions, contraindications must be strictly followed. So when studying for the exam, make sure you go through these very closely. And then general contraindications, we have these listed here. They're also listed in our book. And again, prior to using PAMs, check your texts and literature for additional contraindications and precautions. The ones that I put up here are just the most common ones, so that I see in the textbooks, but there are others, but follow the ones that are most common. Now, I'd like to quickly move into therapeutic exercise if I could. It's used prior to engagement in purposeful and occupation-based activities. Again, you must adhere strictly to the MD's prescription. You must know contraindications and precautions, such as post-surgical, acute injuries, infections, fractures, skin grafts, all those kind of things you need to be aware of. What are the contraindications of doing any kind of exercise? When I look at the doctor's order, I look at exactly what the doctor is asking. Now, sometimes the doctor will give you a prescription that's very general. It will say range of motion. In this case, I might, if the person is post-surgical, I might call the doctor and say, is it okay if I begin with passive range of motion? Then I'll move them to active assist and active. So sometimes it means you need to communicate with the doctor if you need clarification of that order. But if they put an order down and they put passive range of motion, that's all you're going to do. You're not going to do active assist range of motion, you're not going to do passive stretching. So passive range of motion means passive range of motion. You need to make sure that you know the difference between each of the range of motions and why one over the other. So when we talk about active range of motion, you guys have all heard this in school. This is performed using one's own muscle strength. So some common types of active range of motion include your tendon gliding exercises. Functional activities involve active range of motion. So that is the muscle is contracting and producing the movement. The person is using their own muscle strength. So sometimes a doctor will order active range of motion for, like after a wrist fracture, they only want active range of motion. That doesn't mean that you assist the person. That means the person does the active range of motion on their own. Active assist range of motion is performed using one's own muscle strength and assistance of an external force. So things like it can be cane exercise where one arm is helping the other exercise, or even wall walking. They're using their muscle, but they're also using their fingers and the wall to help get them to walk up the wall to get the shoulder moving. It can be you, the therapist, taking and helping to support the arm as they raise it up over their head, but encouraging them to try and contract their muscles. But you're also assisting them. Passive range of motion is performed by an external force, either the therapist, it can be a continuous passive motion machine, it can be the patient using their other extremity to passively move their arm to their end range. So end range is where they feel the resistance or where pain is felt and they can't go any further. So if I take and I passively move my arm up, it's where I start to feel the resistance. That's my end range. Okay. And then, or I raise the person's arm up and they say, oh, ouch, that's it. That's their end range. That's passive range of motion. So sometimes the doctor will order passive range of motion only after surgery. You need to be very clear to the patient. I do not want you to contract your muscles. I don't want you to use your muscles at all. Let me do all of the work. Make that very clear. Now, the other kind of exercise listed here is passive stretching. Passive stretching is also performed by an external force, such as the therapist, the patient's other extremity, to the end range, and then you apply overpressure. So the therapist takes and stretches the person's arm up. I feel the resistance, and then I apply overpressure. So there is a difference between passive range of motion and passive stretching. So you want to be very careful on the exam if they are putting down passive range of motion or passive stretching, knowing that passive stretching is more aggressive. So you're going to the person's end range and then you're applying overpressure. A lot of times after surgery, if a doctor is ordering passive range of motion, one, it means they don't want the person's muscles to contract because you could disrupt the repair. And two, they don't want you to do passive stretching because it's too aggressive and it can also disrupt the person's repair or fracture, whatever it is that they're seeing you for. Now, just a little bit about strengthening. Do not proceed to strengthening until approved by the MD. So you need to be aware of certain protocols, that, for somebody who's like a wrist fracture, common, we begin with, active range of motion, then active assist, then they usually okay to do some passive, and then we go into strengthening. But you need to make sure that once you begin strengthening, that you have approval from the doctor. You need to be aware of that. When we talk about strengthening, we're usually using high resistance with low number of reps. If we were working on endurance, I would be using lower resistance with higher reps. Know your different kinds of contractions. I don't know if they'll ask you about those, but you should be familiar if they say something about an isometric exercise. That's an exercise where the muscle is contracting, but without movement. It's also to keep in mind that this kind of exercise, isometric, is contraindicated for somebody who has an active cardiac history. So you need to be aware if they give you somebody who has a cardiac history and they're saying, which type of strengthening would you begin with, know that isometric is contraindicated. Concentric is shortening of the muscle, and eccentric is lengthening of the muscle. So on the exam, if they give you a question that involves concentric or eccentric, what they're concerned with is the length of the muscle. They want it either in the shortened position or in the lengthened position. In isotonic, there's no real concern about length change, even though there is a length change, but that's not the concern. But the muscle is contracting, but with movement. So isometric is there's a muscle contracting with no movement. Isotonic is there's a muscle contraction, but with movement. If they put anything in regards to concentric or eccentric, they're really concerned about change in length. Strengthening can be completed by hands-on with the therapist, such as you doing isometrics with them, TheraBand exercises, free weights, hand grips, Therapeutic, etc. Strengthening, though, to me, is best addressed during performance of tasks. So a lot of times people like, especially with arthritis, where their joints are, could be somewhat unstable or crepitous, I don't like to take out and use TheraBand with them and free weights and stuff. I'd rather look at strengthening through function. Can they reach up into their cabinet and get a 1 pound box of sugar out? Can they take a plate out of their cabinet? So look at strengthening too, can be looked at through performance of tasks. So don't just think that strengthening is always with weights and TheraBands and things like that. It's also can be done through strengthening, can be done through performance of tasks. That concludes my section of the presentation.